Now, Yelena, let's say New York said, I got my 6 months of treatment. I'm done. I want to go down to Florida. I don't want any more chemo.
Yes.
So do you bring in treatment breaks? Do you change treatment intensity for your first-line patients?
So there's no data to support our recommendation really in gastric, but extrapolating from other solid tumors such as colon cancer and lung, gastric cancer is a very aggressive disease, and if you turn your back on it, it's going to grow. So that's what I tell my patients, and we generally scale back. And I think the important message to get across there is that this is a marathon, not a sprint. You have to plan ahead for toxicities, dose reduce early on as needed for symptom management, but don't stop. If you discontinue chemotherapy, patients tend to then decompensate, and then there's less of a chance to get them to second-line therapy. So we tend to continue 5-FU. If the patient's really fit and is able to swallow pills, capecitabine is also an option because that gives them more freedom from the 5-FU infuser. But those are the recommendations.
And you can crush capecitabine and put it in a tube if you needed to, a feeding tube, right?
It's not indicated, but you could.
You could.
Yes.
Such a stickler, but you could. So Yelena, also, Eric alluded to this study, this HER2 study in second line, which showed that we probably shouldn't continue trastuzumab beyond progression in the first line into the second line. But we were talking earlier, and you made some comments about maybe HER2 status changing as the patient's disease evolves. Tell us a little bit about that data, but also if the HER2 status changes, would anything else change in a patient who's progressed on first-line therapy? Would you ever consider rebiopsying the patient to look for alternate mutations or translocations?
You brought up a great point earlier. In trastuzumab therapy and HER2-directed therapy in gastric is different than in breast. And I'm a big I have a big interest in HER2 and do a lot of research in that field, but I hear it over and over again from colleagues and collaborators. Well, HER2 in gastric is just not as important. It's not a driver. You're barking up the wrong tree. It's just not as important as in breast. What I would argue is that in gastric cancer, because of this heterogeneity that Eric brought up earlier, is that these patients with very focal HER2 expression, that you have to get 8 biopsies to find it, those tumors are really not all that HER2 driven. And in those patients, the benefit from HER2-directed therapy is minimal, and they are the patients that bringing down the survival curves on these studies. What we find is in gastric, patients with low level of amplification due to this focal activity and co-occurring alterations such as RAS, PI3 kinase, which happens in gastric as it is a GI tumor a lot more often than in breast, those patients are not truly HER2 driven. And moreover, if the tumor has focal amplification, but it's not high enough level where you can't even pick it up on NGS, next generation sequencing, those patients behave as if they were not even HER2 positive. And so in gastric, that's a caveat in first-line setting. And what we found on our rebiopsy studies in second-line setting, that what you see as a mechanism of primary resistance just becomes amplified once the tumor becomes trastuzumab refractory. And so those studies that continue the patients beyond progression, I think apply mostly to the general population. But if you have a patient that the tumor is truly HER2 driven, you saw a high level of amplification that persisted at the time of progression, I would rethink that and perhaps either at least seek out a HER2 specific study for that patient or consider using trastuzumab beyond progression, perhaps with a different backbone.
Yeah. And so what is your second line treatment option? What would you do?
So right now, majority of our patients outside of a trial go on a combination of paclitaxel plus ramucirumab, the VEGFR2 inhibitor. That's the standard regimen. It's well tolerated. Most of our patients do not get taxanes in first-line setting, and I think it's very important that NCCN tighten their guidelines. You remember, majority of the folks out there are not gastric cancer experts, so they need a go-to place. And if you make it too open and put every New England Journal of Medicine paper on the NCCN guidelines, then the practitioners don't know which paper to follow. So, really clearly stating that epirubicin is out, Folfox is in, is really important. And so the majority of our patients then in second line get paclitaxel plus ramucirumab.